Okay, hello everybody. I'm Dominique de Ziegler. I work at Untitled in Paris, France, and I have the great pleasure and the honor to actually introduce to you the speaker of this webinar today, Dr. Nikolaos, who needs a little introduction because he is known by everybody in the field. Nikolaos is the head of reproductive medicine in the department of Dexeus Mujer at Dexeus University Hospital in Barcelona, Spain. He's also a visiting professor in the Department of Reproductive Medicine at the University of Ghent in Belgium. In the past, Nikolaos has served as medical director of the Center of Reproductive Medicine in Brussels until 2017. And he was also then the professor of obstetrics and gynecology at the Free University of Brussels, VUB, until 2019, and also a professor at University of Aarhus in Denmark until 2020. Nikolaos is a renowned investigator in the field. He has worked on several projects, international multi-center trials. Nikolaos is a section editor of RBM Online and a member of the ASHRAE Guideline Development Group for ovarian stimulation. Ovarian stimulation is really something that has no secret for Nikolaos. Nikolaos has published over 150 articles found in PubMed, and with an index of 36 in the EASY Web Science Index. So Nikolaos has really gone around in the field of ovarian stimulation, and we have the great opportunity today of hearing him talk about new strategies to optimize ovarian stimulation for IVF, ICSI, window to the future. It's really a field that is being revolutionized by several items that Nikolaos is going to underscore, and I hope you enjoy this talk and you'll learn a lot. Nikolaos, the floor is yours.
Thank you so much, Dominique. I would like to thank IBSA for the invitation, of course, to thank you for the kind and a very nice introduction. It's really an honor when I'm being announced like this from a person that has been in the field so many years and has put his stamp really on this. And I will try to give an idea to the people about novelties. We are living in an era which is changing. We're living in an era which stimulation is getting modernized, and we will see what is the window to the future to this ovarian stimulations that we all do in our everyday clinical practice. These are my conflict of interest, and I will talk about evolution, revolution, the way that we have evolved all these years. Because we are here because of this. Louise Brown was born in 1978, and this is the reason why I'm also working in the field. And actually, we're the same year. I'm born in 1978. So after the birth of the first IVF baby, there has been a lot of changes. There have been a lot of changes. There has been a lot of improvement of development, not only in the lab, because sometimes we focus only in the lab. If we try to see the way that we're doing our ovarian stimulation, it's completely different. IVF, Louise Brown, and the first IVF was in an unstimulated cycles. We didn't have any medication. But since then, a lot of things has changed. We managed to realize that we can use drugs like clomiphene to induce an endogenous FSH stimulation. And this was the first step, understanding that we need multifollicular development. Then we realized that maybe it's better to go with injectables in order to induce even more follicles. But then we realized that multifollicular development can lead to premature luteinization, premature late surge, and we started using analogs to control the late surge. But then we realized that this is not enough because we can get a lot of oocytes, but we need safety and comfort for our patients. Patients do not want to inject all the time. So we went to the antagonist protocol, and lately we realized that maybe it's better to freeze all, to freeze all the oocytes, all the embryos, in order to avoid this complication, which is called the HSS. So all this beauty led us today. How is ovarian stimulation in 2020? What do we see? Well, if you ask me, I say this. I see an antagonist protocol. Why an antagonist? Safety, convenience, low or no HSS. So how can we optimize in 2020 the antagonist protocol, and what is our perception for the current and future ways of treating our patients? Because the patient comes to you and you think that this is the major part, but sometimes there are things that we can do before. There are things that we can do during stimulation, and of course we have the aftermath after we get the oocytes and we create our embryos. So in all these parts we will talk about pre-treatment, medication that we give or we tend to give before initiating our stimulation, and we have to see why we do it. What we do during stimulation, when we start our stimulation, which day, why is it linked with the menstruation of our patients and we cannot do it on day 25 of the cycle? How we control the late surge, how we used to control the late surge, and how we can do it in different ways, cheaper ways. What is the intensity of stimulation that we use? Should we stimulate a lot or a little? And of course, what is dominating lately our labs? Freeze all. We tend to freeze all, and if you see what's happening in the literature, the vast majority of the clinics intend to go more and more to freeze all embryos. So I will start, not to lose time, with pre-treatment. Why do we pre-treat? Why do we need to give something to our patients before our injections? Aren't injections enough? Well, for several reasons. Number one, scheduling. Summertime is coming. We want to avoid having a pickup on a Saturday or Sunday because apparently we or the patients would like to be out their weekend. Or on the contrary, they might want something in a weekend because they work every day. Secondly, synchronization. The major drawback of the antagonist protocol is the follicles are not so synchronized. You do your ultrasound and you can see exactly the same time if you're doing an agonist or an antagonist protocol. And thirdly, medication to increase the ovarian reserve, if we believe that this is feasible or maybe a myth. So I will start and I will talk to you about the pills. Giving pills in women that are trying to get pregnant. This sounds really strange, but this is the truth that we do. And in Spain, I can tell you that the vast majority of the centers are using pill to program. And when I came from Brussels, that I have been working to Spain, I was afraid. And this is true. If you haven't worked with pills, you have read all this literature, to pill or not to pill. And to pill or not to pill, because if you read this meta-analysis by George Grisinger back in 2010, it says to you, no, 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 don't use it. Why? Lower pregnancy rates, more FSH needed. So when I came here, I said, what are we doing? Do we want to harm our patients? Because if you see the studies published, they tell to us that there is a borderline significant, but still lower ongoing pregnancy when you use pills compared to no pills. Of course, look the dates, 2006, 2007, and most of them, older studies, didn't use a fixed pill-free interval for at least 5 days before starting stimulation. So coming back, I was a little afraid and I said, let's try to see what we have. We're using pills, let's analyze them. And we published this back in Human Reproduction in 2020, this year, in which we, in retrospective manner, analyzed all the patients that they were treated with oral contraceptive pill and no pill. What we have seen, first of all, after doing multivariate logistic regression analysis, we have found that when you're using pill, which is the red line, you always had a significantly higher number of oocytes retrieved for a given androfollicle count. What does this mean? You use pill, you recruit more follicles, you synchronize, which is beautiful, which is nice, and which is what we want. I want to get the maximum out of my patients if I can. But on the other hand, what we have, if you see in the literature, you will realize that the problem was not getting the oocytes because they had a quite good number of oocytes. What Ziegler has told is that there might be a negative effect on the pregnancy rates. So what we did is we realized not only the fresh live birth rates, but also the cumulative live birth rates following the first stimulation in our patients. What we managed to find is that neither in the fresh nor in the cumulative live birth rates we found any difference in lower pregnancy rates, lower live birth rates when the pill was given. And for this reason, I believe using the pill is justified, despite the fact that the literature or guidelines had told us that be careful. I think the jury is still out and we need more evidence, but based on our huge study with 4,000 patients, we failed to find any difference and we continue using the pill. On the other hand, we are living in the era that we believe that giving medication can actually change the course of our patients. And when I'm talking about patients, I'm talking about the difficult patients, which are women with low ovarian reserve. So androgen pretreatment has been running in the news, has been running in our articles, in our reviews, the last 30 years. Everything began from this part of group, the group of Ventola and Vail, doing studies in premates, telling us that giving testosterone of 3 or 10 days in premates, you can increase the number of follicles. And this has been seen by experiments where the ovaries were taken out, they were cut into pieces, and the follicles were measured with a microscope. So very strong and very well conducted experiments. Also, similar experiments have shown to us that whereas control or FSH does not increase the FSH receptor, when we use androgens, testosterone, we see that there is an increase in the FSH receptor content after 3 or 10 days of androgen administration. Question: is this the future? Do we have evidence? Can we use it in everyday clinical practice? And simple answer: no. Why? Because it's still experimental and we still don't have robust evidence. But we are going there. We're doing a very big study in Texas with collaboration with different hospitals across Europe, in which we give actually 2 months of administration of testosterone before a long agonist protocol in women with low ovarian response, in order to see if this can change the course of the low response in this difficult group of patients. We're talking about a big study that it's done in 4 countries: Spain, Belgium, Denmark, and Switzerland, with highly reputable investigators like Peter Humaydan, Anja Pinborg, Christian de Heiter, Dominique Stoop, I can't remember more. Yes, I will certainly not tell someone, also Christophe Bloquel from Brussels, and many centers from Spain, including the sales. So let's wait for the results. I think this year we might have some interim data that we can share with you, and we can see if this can be a future for women with low ovarian reserve. We're talking about a big study, Polonia for responders up to 43 years old, 400 patients with an interim analysis at 280 women that might increase the sample size to 700, and a double-blind placebo-controlled trial, very well designed. Difficult to recruit, but I think now we're in 180, almost 200 patients, and we will certainly very soon do the interim analysis. Going to the second part of the stimulation, we will talk about when to start. And when to start, it's a great question. Why? Because it's something that we usually do when we're talking about the fertility preservation. Patients are coming, cancer patients are coming, and you need to start now, or you need to start yesterday. So you need to start independent of the day of menstruation. But this can be also a method of scheduling. Why am I telling you this? Because it's really sometimes difficult to understand why we're stuck to this second or third day of menstruation. Wouldn't it be beautiful, nice, more freedom for us to be able to start whenever we want? And this can be feasible if someone realizes how the follicular waves work. And actually Bergold in 2012 has published a beautiful article showing to us that during one cycle, you don't have only one follicle. You can have 1, 2, or even 3 follicular waves that they start in different days of the menstrual cycle. So why not, instead of getting this follicular wave, we can get this follicular wave? And if we see in the literature that Nathalie Mancini from Spain has published this in Human Reproduction, you will see random start stimulation is something that has been tested in small, retrospective, not randomized trials that has shown that you can start in the luteal phase. Instead of starting day 2, you can start day 19 or day 15 or day 16. And what you have very good pregnancy rates. Of course, we're talking about small series and retrospective studies. Also, we have seen the famous studies from Kwang and Ubaldi regarding the duostim, that you start one cycle and then you start the second cycle after 5 days. And we have seen studies talking to us about random stimulation, day 2, day 12, or day 17 of the cycle, showing very promising rates. So why not to be able to utilize these different follicular waves and start a patient that this is coming to you from 300 kilometers away the first day that she comes? Patients come and they want to start. Start me now, doctor. And what we say to them, oh no, I have to wait till your menstruation. Why not? Starting anytime. And then I will show you one study that we have done in order to evaluate not only the number of oocytes between follicular and luteal phase stimulation, but also the genetic content of the embryos. So what we did in oocyte donors, we did 2 stimulation cycles. One stimulation cycle starting in the follicular phase and another stimulation cycle starting in the luteal phase after 1.5 months. And oocytes that we got from the follicular or the luteal phase stimulation were fertilized with the same sperm that has been frozen before stimulation, and then we want to do PGTA and transfer of a euploid embryo. What we found out, this is the study, 44 donors, PGTA, exactly the same patient, exactly the same protocol. The only difference is this: follicular phase stimulation starting day 2, luteal phase stimulation starting day 7. And what we found, absolutely no difference in the number of fertilized oocytes, in the mean number of biopsy embryos, and of course, in the mean number of euploid embryos. And we're ready to write and publish this article, which I think it's very important and very interesting. So starting anytime can be an option. On the other hand, what we want is to control the late surge. We can start anytime, but sometime when the follicles reach 14 millimeters, 13, 14 millimeters, we need to control them. And what we're usually doing, we're using analogs. Thankfully, we moved for the old-fashioned long agonist protocol to the more patient-friendly antagonist protocol. But even this, injections, which is burden for the patient to inject morning and night, and of course, costs. An antagonist is not cheap. So why not being able to go to novel methods and lower the costs? And if we try to see how we can do it, we will have to think how nature thinks. This is how the hypothalamic pituitary ovarian axis works. And we know that the estrogens that they are increasing, they are produced, have a positive feedback in terms of a late surge in these patients. So what we're doing now, we're blocking this late surge in the hypothalamus hypophysis levels. By using the GN-rate analogs, what we do, either we use a long agonist with a flare-up protocol and a subsequent downregulation, or in the most modern way of treating, we use the antagonist protocol. Direct suppression, immediately, very rapid action, and we block the late surge in the middle of our stimulation. But why not go back to our books? Because if you see this axis, you will see that when you're stimulating your patients, progesterone might have a negative effect on this axis and actually block the late surge. This has been shown in the past, and sometimes we forget the experiments that we have done, and they are very important. And one of these is this experiment by Skinner, in which they were put implants of progesterones at different levels, and they tried to evaluate the peaks of GnRH and LH. You see, these are the progesterone implants. Insertion of the implants, high progesterone levels. Withdrawal of the implants, very low progesterone levels, and insertion of the implants at higher levels. And what you see, this is what's happening with the generates pulse, and this is what's happening with the LH surges. The pulses of generates and the surges of LH are lower and less frequent when progesterone is there. When progesterone disappears, they become very frequent and very high, and when you insert progesterone at higher levels, you make them disappear. So you can beautifully block your LH surge by using progesterone. What is the problem? That you destroy your luteal phase and you need to freeze all. But aren't we freezing a lot? So why not to be an option to use it in several patients, especially if we see that it's efficient? Because if you see the first RCT, it has shown that in terms of oocytes, it's worked well. The mature oocytes is the same, 15.1 versus 14.6, even better with the medroxyprogesterone acetate. And you see the levels of LH, they're beautifully and nicely controlled during the whole stimulation, either if you use a progestin or a generates antagonist. However, Houston, we have a problem. And what is the problem? This report, reporting on pregnancy rates, according to the study, while everything was beautiful in terms of controlling the LH surge and in terms of number of oocytes, what has been seen is when you use these oocytes in your recipients, you had a significantly lower clinical pregnancy, ongoing pregnancy, and live birth rate when progestins have been used. And this has been shown that the antagonist is giving you actually a 2 times higher adjusted odds ratio for pregnancies. So be careful, the jury is still out. Following this study by Beccaria, do we have more studies? Yes, more recent RCTs have been published, one in women with PCOS, which unfortunately is showing that in the women that they were treated with progesterone, the PPOS group, they had lower clinical pregnancy rates, not significant, but you see a trend per transfer which was significantly lower. Of course, this result has not been replicated by the recent oral communication coming from the EV group by Giles, in which it has shown that either when you use in oocyte donor a progestin or antagonist to block the LH surge, you lead to equivalent and very good implantation rates, very good ongoing pregnancy rates, and very low pregnancy losses, similar between both groups. Is the jury still out? Well, I think it's not out because when we're using any medication, we need to see not only the short-term, but also the long-term effects. And what we're talking about there, we're talking medication, especially the MPA, the medroxyprogesterone acetate, which are contraindicated during pregnancy. This is clearly mentioned in the summary product characteristics. And if you see the safety of the live bones, the Ziegler and the twins, you will see that in this study by Zhang, it has been reported that there is no difference. Though no difference in neonatal outcomes, no difference in malformations in children and terminated pregnancies. Of course, let's go and dig behind the numbers. Let's go and dig behind the numbers because although you don't find any difference, you have this adjusted odds ratio, 127 or 1.7, which is not, of course, significant because of the very wide confidence intervals, 0.63 to 4.58. And why is this? Because of the very low number of events, 20, 14, 15, 3, 6. So you don't have many patients or many malformations to make sure if there is no difference. But if I have a medication, I'm using a medication that in the future might tell me that the kids born from this might have a 70% higher risk of congenital malformation, then I have a problem. And then I have a serious problem. What we're doing in Texeus, we have a study, the ProgStim study, which is more than halfway, and we're expecting to finalize it soon, in which IVF patients, before their menses, they're using 2 stimulation protocols, 2 consecutive cycles. Cycle number 1, stimulation with an antagonist protocol, the typical antagonist protocol. After 1 month washout period, progesterone stimulation protocol. Fertilization of these oocytes delivered from the first and the second cycle with the same sperm that has been frozen, genetic screening of the embryos, and transfer of euploid embryo. And these are women that they are 36 to 41, that they're using 2 consecutive cycles, so they have a relatively nice ovarian reserve. The only difference is this: GnRH antagonist versus micronized progesterone. And if you ask me, are you afraid of this? Well, I'm using a progesterone that is in the market. We're using an oral progesterone, micronized progesterone, which can be also with injections in the future, but in the end, it's something that it's within the label, within the summary product characteristics, and not a medication that we use for the first time and it's contraindicated. Following this, the last part of the whole process, which is called ovarian stimulation, is how to stimulate. What is your intensity of stimulation? How do we select our dose? And whether we go with a mild or an intense or a conventional stimulation. Because we're living in the era that there's a lot of debating. How much is enough for you? 150, 200, 225, 300, or 450? How do we tailor the dose of our patients? We always have our ovarian reserve markers, and it's a revolution. Why? Because we can predict. We can predict beautifully excessive response when you have your AMH on your androgen follicle count, and you can predict in the same way very well when you're using your AMH, your FSH, your androgen follicle count, and your age. But still, ovarian reserve markers, what they tell you is numbers. They told you about reserve and not sensitivity. And what we certainly face many times, especially when we use antagonist protocol, is this. The group of Renato Fanchen has published back in 2011 about the follicular output rate, which has an amazing clinical significance. This. You can have a patient with a beautiful ovarian reserve, you stimulate them with your gonadotropins in a nice way, and you end up with this. A full asynchrony, 3-4 follicles, and your other follicles are not developing. Because your follicles have a different sensitivity. And there has been a huge debate regarding the role of pharmacogenomics, or pharmacogenetics, I would say, like that specific genes that they are based on the in controlling the FSH receptor and the FSH gene can be responsible for the way that our patients respond. And one of these has been the FSH receptor and the FSH gene. So we just finalized one study and we're sending it out for publication, in which we included women from 2 different ethnic origins. Caucasian women from Europe, 164, and 200 women from Asian origin from Vietnam. Women that they were good prognosis, 18 to 38 years old, very good BMI, first or second stimulation cycle. And what we did, a fixed antagonist protocol with a fixed dose. We were not allowed to change the dose. 150 units during the whole stimulation process. And these women were good prognosis. Take out poor responders, low AMH and low androgen follicle count excluded, and PCOS women excluded. And what we did in these patients, we stimulated them for IVF ICSI, and before the oocyte retrieval, we had consent, we extracted blood for DNA isolation, and what we did the genetic analysis. And after knowing the oocyte retrieval or the number of oocytes, we checked for SNPs, for single nucleotide polymorphisms in genes related to the FSH receptor, the first 3, or the FSH beta gene. And try to find if the polymorphisms that have been reported in the past to be associated with low ovarian response are higher in the patients that we had a low ovarian response. So what did we find? And what is clinically relevant and what is clinically irrelevant? Because in the end, we have to distinguish to realize that it's another thing to talk about statistical significance and another thing to talk about clinical significance. So these are the polymorphisms we checked, at least for the first or the second. What we found is that the percentage of lower suboptimal responders, women with less than 10 oocytes, was significantly higher in the abnormal groups. Let's say that this is the normal group, the homozygotes, that the wild type, 21.5 versus 32 or 27.6. So when the gene was altered, there was a significant difference of more low responders in the group with the abnormality. And then the well, this has been seen in this polymorphism, not so much in this one. So is this clinically significant? Wait, let's see what it means in actual number of oocytes. Because if we're talking about in actual number of oocytes, we're talking about the difference of one oocyte, 13 versus 12.1 or 11.9. This difference is completely clinically insignificant. In a normal responder that I can get 13 or 12 eggs, this one egg will not make a difference. Apparently, this egg will make a difference in a patient that will have a low ovarian reserve, and I would like to go into this. But this doesn't demonstrate to me that in clinical practice, I can use a biomarker that when I implement it and when I do it, I can select the patients that they will need higher doses because the clinical significance is small. And this is the same because when we're talking about the follicular output rate, we fail to find any difference. So, although these SNPs might play a role, biologically might be associated, clinically the relevance is minimal and it should not be implemented or recommended as an analysis in clinical practice, at least for the moment. What we're doing now is we're planning other studies with these samples and we want to evaluate different genes, different polymorphisms, different genetic variations that can be associated with this low response, and we will continue our research until we find it. But in the end, we need to realize, or we need to talk whether we want more oocytes, because if you ask me, we have proved with studies that we have done, big studies with 14 centers in Spain and Belgium and 15,000 women, that yes, getting a higher number of oocytes is not harming your patients in terms of live birth rates. In this study published in Fertility and Sterility back in 2018, we have seen that the more oocytes you get, the higher the cumulative live birth rates. Talking about cumulative live birth rates that they reach 70%. This is magnificent. This is very interesting. And if you ask me if we need for all, I would come back with another question. Are all the patients the same? Because we have women of different age, young and older patients. I wish we had these patients. Normally they come at this age, or they even come at this age where nothing can be done. We have different patients on BMI. We have women that they are overweight or women that they are obese. And in these women, you would certainly need higher doses of gonadotropins. You have different ovarian reserve markers. You have different causes of infertility, but also you have different needs. You have secondary infertility patients that they will not need 57 oocytes because it doesn't mean anything. You don't need even 15 or 20. You might do your job with 10. So you need to be rational in your stimulation. Of course, we know that advanced maternal age is a distinct category. Why? Because in these women, we have shown that you need oocytes. You need oocytes to compensate for the aneuploidy associated with the age. And we have shown in this study published in Human Reproduction in 2018 that if you go from a certain number to a higher number of oocytes, at least until the age of 43, this is interpreted in a significantly higher cumulative live birth rate for all the ages. Of course, don't expect anything in women more than 43. Age, nature is much more intelligent than any doctor, than any stimulation, than any medication. And above the age of 44, if we're talking about aneuploidy rates of 95%, what do we expect? On the other hand, if we have younger age women, we realize that there we have very good and high euploidy rates. What Franasiak has shown to us is that up to the age of 36, the euploidy rate is 70%. 7 out of 10 of the embryos would be normal. So apparently, if you see this study by Maureen, you will realize that even with less oocytes, you can do your job. This study has shown that in women less than 38 years old, independent if they are low responders, mean number of oocytes of 4, or normal high responders, mean oocytes of 14, you will realize that the blastulation rate is always high. 50% of these oocytes will become blastocysts, and only 30% would be abnormal. And your euploid embryo live birth rate would be very high, up to 70%. So why do you need so high? But when we're talking about poor responders, is it something different? And are all poor responders the same? And I'm talking to you about this because we have participated in the guideline development group where we came up with this recommendation, which is, I would say, political. I have been part of this group, and we had a lot of debate, and we came up to the conclusion that it is unclear whether a higher gonadotropin dose is recommended over 150 for predicted poor responders. But before adopting this, because for me in everyday practice doesn't say anything or says very few, I would say, are all poor responders the same? Because we have poor responders with a very poor ovarian reserve, 1 or 2 follicles, and there I would certainly agree with the recommendation, because if you have 1 follicle, no matter what you use, you will get 1 oocyte, but you might have women with a good ovarian reserve. So although based on this, it came in the last month Human Reproduction, an article telling about individualized stimulation, suggesting clearly stop using high FSH doses in predicted low responders, our vision is slightly different, slightly more individualized, because we believe, and I believe, that every patient wants to get the best treatment care. So instead of this, I would say no to mild stimulation to low poor ovarian responders, because it is really time to realize that not all of them are the same. There are poor responders with a very bad reserve, that definitely 150 or even less would be enough, but there are poor responders with a very promising ovarian reserve, young women, that you can get this 1 or 2, 3 oocytes, which you have to fight for, because these oocytes in a young patient have 50% to become blastocysts, and you have to be consistent in your treatment, in the way that you treat your patients, in order to give them the best benefit. In the end, some of us might say, okay, I would freeze all. This is the final part. I get my oocytes, and I might use intense stimulation, although in some patients it's not recommended. And in the end, I would freeze all. This is the future. This is the best. This is what we have to do. But when do we freeze, and why do we freeze? Some of you might say, freeze all for all. Or some of us might say, freeze all in high responders. Or some others might say, freeze all when you have progesterone rise. Which is the golden group to freeze all? Why has it been developed, freeze all? Freeze all is freedom. Freeze all, freeze all. And the freedom is not on doing it for everyone. The freedom is doing it in the women that they are at the risk of OHSS. Why? Because by segmentation, you can avoid OHSS. Some of us might think this is an opportunity to stimulate bombard your patients with high doses. But of course, bombarding leads to this. It is what you think or what you like, because apparently this is not what I perceive as an optimal stimulation. This is an excessive response, and this patient doesn't need this image. This patient doesn't also need this image to have ovaries that they can have a torsion, because this can occur. Your agonist and your freeze-all cannot avoid a torsion, and we have seen, and I have seen, torsions after intense stimulation. So freeze-all is the future for high responders, because we have evidence that it works, but we should rationalize. The other part, which is for some of you definite road to freezing, but for me it's still unclear, is when we have late follicular phase progesterone high. And I'm asking you this, why? Because we have been dominated in the literature with a lot of studies, with a lot of meta-analysis, seeing about the tens of thousands of patients that when we see numbers, we get obsessed, we like it, we love it, the 60 or the 70 or the 100,000 patients that they say when your progesterone is high, you have lower pregnancy rates and you need to freeze all. But this came from this initial study by Ernesto Bosch, telling us that when you use a specific kit to measure progesterone, when the levels were more than 1.5, the live birth rates were becoming very low. And this was again shown by large meta-analysis of 60,000 patients that they were heterogeneous, patients that they were using different assays, different kits to measure progesterone, and we know very well that when you use the one or the other, you might have up to 20, 30, or even 40% variation in your levels, so just be careful when generalizing. So Why not to freeze, or why yes to freeze? Is it equally effective or not? Well, we published back in 2019 a very interesting study in which we measured the progesterone on the day of triggering during 4 different intervals, at 8 in the morning, 12, 4 in the afternoon, and 8 in the evening, every 4 hours, in the same patient. And what we have seen is that during this day, there was a 44% decline. Patients from 1.5, they went to 0.7. So how can I rely on a single value of 1.5 when I measure it whenever I want? And the reason I'm telling you is that in this large meta-analysis, or in this study by Ernesto, the patients were not coming in the morning all the time. They might come here and here and here. So a patient here has a normal value and a patient there has an abnormal value. In the end, you might ask me, and why do you care, Dr. Polyzos? In the end, I have this golden embryo after my super stimulation. I follow what you say, or I follow what I believe. I give the best out of it, and I have a beautiful blastocyst, AA, and I'm ready to transfer. So why not to transfer it in an ugly uterus? If I'm thinking that my uterus is bad because of the progesterone, it's dependent if I don't know what's the level. The story is there. It might be 1.7, 1.9, 2.3. I freeze all. But what I would like to ask is, you see this ugly, bad uterus ready to eat your embryo, but are you sure that this freeze is ideal for all the patients, or there are embryos that we can damage? And the reason I'm telling you is that although we participated in the study by the group of Anya Pinburg, published in BMJ, we have seen that freeze-all can be for most ongoing pregnancy rates in an unselected population, and live birth rates, according to our study in BMJ, demonstrated absolutely no difference. Excellent result, very high live birth rates. But not all the patients are the same, and we have reports going in the opposite direction. For example, this analysis from the SAR data by Archaya, showing to us that when you freeze all or freeze, which is the freeze all is the red, you see that you have significantly higher pregnancy rates, live birth, not significantly, sorry, higher live birth rates when you implement it in women with more than 15 oocytes. In these patients, freeze performs better than freeze. But when we're talking about normal responders, this difference disappears, and it appears to be more or less the same. And finally, when we're talking about low responders with 1 to 5 oocytes, you might see that the freeze is performing better. Is it the same when you have advanced stage women? Can the embryos survive the same way the freeze and thawing? Are the same quality the embryos, and do they have the same chance? And if I'm freezing at levels that eventually have no effect on my pregnancies, am I doing the best or the worst of my patient? And then, even if we freeze all, what are we doing? Are we struggling with a growing number of abandoned embryos? CBC published this, and CBC published that even in patients that you have 1 or 2, but especially in patients that you can have after up to 9 and 10 cryopreserved embryos, almost 30% will never get back. Try to find a way to destroy them and accumulate them until when? 2,200. What are we doing? Why do we need these numerous embryos if the patients are not going to use them? We are losing the focus, and this is very important to go back to track. In the end, to conclude and leave the floor open for discussion and answer your questions, let's see how I see ovarian stimulation 2020. Dr. Polyzos, do we pre-treat? Well, we're using the pill, and we're continuing to use the pill, and we don't have any impairment in pregnancy outcomes. We want the best for our patients. I think our data are robust enough to demonstrate that the impact is not there in live births and cumulative live birth rates. Androgens, in terms of increasing the ovarian reserve, is a dream that might come true, that might not come true. Robust studies are needed, and we wait our results to demonstrate if this is the future. On the other hand, we have successfully advanced in terms of the stimulation itself. Starting day, yes. Random start and freeze all may be the tool for patients in the future. Start now, stimulate, freeze all. That's beautiful. On the other hand, progestins can control the late surge. Maybe in the future, if we have data about safety, more data consistent about safety, we can implement it in clinical practice, again, along with a freeze-all protocol, because we cannot transfer interference. And in terms of gonadotropin dose or intensity of stimulation, number of oocytes are associated with pregnancy rates, but we need to be rational, because not all patients need unlimited number of oocytes. Unfortunately, when we select our doses and we do our magic, sometimes we might end up having a huge number of oocytes. So we are living in the era of revolution. And the revolution is freeze-all because it's freedom, because we can eliminate HSS. And it's definitely the best option for high responders. We can do it, and we have to do it, and we have to adopt it in this population. In terms of progesterone elevation, I'm not a non-believer. I believe the story. I don't believe the cutoff. So if you cannot give me, ladies and gentlemen, a true guidance when to freeze, is it 1.5, 1.3, or 1.9? And not tell me that you have to analyze the data in your clinic. I know, but this is like very hazy. I want clear-cut questions and clear-cut answers. Can I freeze at 1.5? Can you tell me for sure that I'm harming? No, because of the lack of standardization. Standardize your methods, do a proper study, give it to me, and I buy it. Otherwise, I don't. In the end, we have to realize that freeze-all is a revolution, but like every revolution, you need to apply it to the right population or the right timing. Revolutions are happening all the time in our lives, but we know the time that they can be successful and time that they cannot be successful. And here is the same. We need to know the patients that we apply them and they can work. Because in the end, ice is beautiful, but it's not made for all. Be aware of ice. I'm telling it to you because apparently there is a danger walking over thin ice. What does this mean? If I have the right vehicle, the right mode, or the right patient to apply my ice or freeze-all, I can do a beautiful ride and I can have a beautiful stimulation and I can have a beautiful outcome. But if we try to implement it where we shouldn't, Houston, we have a real problem. So you have to deal with this. Thank you so much for your attention. I'm looking forward to answering your questions.
Nikos, this is just great. I told you before that you were going to have a great talk, and actually you convened with me that this was truly fantastic. Now, Nikos, this is not time, and actually there are a few. First of all, I want to compliment you on the work that you've done on the pill. There was a dark cast pill, particularly from the Griesinger meta-analysis that you quoted, which showed a decreased outcome in patients who were pre-treated by the pill, antagonist patients pre-treated by the pill. You rightfully emphasized the fact that the interval between stopping the pill and starting the stimulation has to be of 5 to 6 days. And that in that meta-analysis by Georg Griesinger, there were at least 2 studies that had only a 2-day interval, which is in many ways not right. But there's something else, and I want to push you in the corner there. The meta-analysis by Georg Griesinger, all the studies, including that meta-analysis, use recombinant FSH. And actually, this is understandable because the maker of the antagonists were also the makers of the other recombinant FSH. Now, when we use the pill, and this has been shown by groups, Zev Rosenwax and others, when you use the pill, you induce a suppression of endogenous granulation of LH, which is much more profound than what you have with the agonists, for example. And therefore, the question is, the poor outcome of those studies reported by Griesinger could also have been been a result of the fact that there was not enough LH. And if the LH, endogenous LH is too soon, you might to complement your stimulation with both FSH and HMG. What do you think?
You're completely right, Dominic. Very beautiful observation. This is true. All the studies have been done with recombinant FSH, and we know very well the pill has an impact in two ways. Either it can affect endometrial receptivity, and this has been shown by studies, especially if you have a short interval. But the other very important thing is that you have a great suppression, much more than a non-pill cycle in your LH levels. So potentially, this can be interpreted by the lack of any LH activity supplementation in this population. So this can be a reason. In our study that we have analyzed our data, we have seen that independent of what you use, recombinant FSH or a combination with HMG or an HMG pure, we didn't find any difference. This is really interesting. Of course, I need to underscore also, Dominique, that we had a shorter duration of the pill. We go to 15 days and not to 2 or 3 weeks, not to 3 weeks or 1 month of pill, that in many of the studies. So certainly in the long duration of the pills, when you have a huge suppression of your LH levels, I agree with you that the LH activity might make a difference, and this can be a reason why we didn't find the difference in the studies, why they found the difference in the studies by George Griesinger, including the meta-analysis by George.
All right, very, very nice. This is a good point. Now, in your talk, you beautifully showed that pre-HCG progesterone, pre-triggering progesterone actually decreased through the day from morning to evening. Do you think that this actual fluctuation through the day is due to the adrenal and to the rise in the ACTH occurring early in the morning that actually makes the adrenal participate in the progesterone level? And do you think that this could actually be an argument for using the short-term corticoid treatment for knocking out the adrenal?
Thank you so much, Dominique. No, I personally believe if you see the studies that have been published also, there is a study by the Danish group that they have shown that there is a circadian fluctuation in the progesterone the endogenous produced. Of course, the progesterone that we produce just before the HCG, probably it's coming, there is a beautiful paper by Octem in Human Reproduction telling us that it's coming through the two-cell, two-gonadotropin theory. There is a part of genes that they are upregulated or downregulated. So what is happening, it's accumulated progesterone from the granulosa cells, and this is the reason why it's increasing. So it's more likely to be associated with the way that you stimulate. And there has been studies, also some studies coming by Fatemi, telling us that when you reduce your stimulation, the final days of stimulation, you might have better progesterone levels. So what I believe is either it's the endogenous production or it is related to the time of the injection, because always in our studies we're doing the injection, the last FSH or HMG injection in the night. So the shorter duration from the time of the injection, the higher the progesterone values. This is my theory and what I believe based on the studies. I don't believe that I would use corticosteroids in these patients, but on the other hand, my message that I want to pass is that I cannot rely on one single measurement. This is my important thing, Dominic, because if you tell me that I freeze 1.5 and I know that the same patient, if it comes with 4-hour difference because I have my consultation in the evening, or she missed the metro, or she missed the bus and she couldn't come at time, and instead of having 1.51, I'm adopting a completely different strategy to freeze. And this is not the way to do science. This is cooking. And we're not cookers, we're scientists, we're doctors, and we need to make it in a correct way.
Also, there is, I mean, you're talking about revolutions and new discoveries and new practices in ovarian stimulation. And one of them that you really beautifully addressed is the use of progesterone instead of the antagonists for blocking pre-ovulatory ovulation. The use of medroxyprogesterone acetate has been pioneered by me, originally, essentially for reasons of cost. Now, they use methoxyprogesterone acetate, and you also alluded to the fact that you actually might use micronized progesterone. But you went very rapidly on this. Do you think that some of the negative impact of MPA could be due to the fact that this molecule is long to metabolize, and that possibly this negative impact would not be seen with micronized progesterone?
One is this, I assume, and secondly, micronized progesterone, we're using it in all our patients during luteal phase support. So all our embryos are getting tons of progesterone, of micronized progesterone. We're not using MPA. So I don't know if there is any impact. I cannot tell you for sure if there is an impact in terms of malformation, but it would be much more willing to use a progesterone form that we already use for luteal phase support, which can be vaginal, subcutaneous, something else, but not the progesterone that we're not using during pregnancy because we don't know about the side effects you have on the embryo.
And obviously, they probably use MPA because this is the cheapest product available. Yeah. And this new development in ovarian stimulation are really great because they're going to modify what we do. I want to challenge you on one point. We have admitted that the survival of oocytes depends on the age of the woman. And from the group in EV, we know that the survival is different from egg donors who are pretty young, from what you find in older women, even old women. Now, I want to challenge you on the fact that you actually said almost the same about the embryos, and this may not be the case. And I want to, for this, put you in front of the observation by multiple groups in the US who do PGTA, and that include Richard Scott, for example. And in PGTA, they have shown that implantation rates of euploid embryos is age independent. And therefore, the older women have a small number of euploid embryos, but apparently they survive well the freezing, the embryos, contrary to the oocytes. What would you say about that?
Thank you so much. I love it. I completely agree with you that I don't believe that the implantation would be better. What I tell you is I don't know. We have strong evidence and we love freeze-all and we go to freeze-all. But my question is that, are you sure that in a 41 years old woman, if I freeze the embryo and I thaw it, it will thaw well? Or we have seen this 2 or 3% of the embryos, because this is what it says, 2 or 3%, they will not survive post-thawing. Who are these going to be, these embryos? The lower quality embryos, which is probably from the older women. There would be the quality of the embryos coming from older women. So what I'm telling you is that I don't have evidence about this. I'm challenging us. And we need this challenge, because where is it better? I freeze in a woman that they have one embryo if I am sure that freezing is better than transferring. But sometimes, you know very well that there are groups that they go against the PGTA and they say that it's better because of the mosaic embryos. I don't know. I like PGTA and I'm using. I'm not telling you that I'm not doing it. But if you have one golden embryo, is it better in your fridge or it's better in the uterus? I cannot ask you. I cannot tell you. I cannot tell you this. I'm not quite convinced, and I think we need evidence and we need long, large studies to prove it. But if I'm freezing just for a single progesterone measurement, which I'm not sure if this is the case, should we do it? I don't know.
Nikolaos, I really want to congratulate you because you surprised us through this talk. You got us into novel things, a novel way of seeing things. And you have been able to actually mingle together both the science and the common sense. And sometimes we go too far on the side of science and we forget the common sense. And you put those two guidelines, those two directions together in a beautiful talk. And I thought that all of you enjoyed it and learned as I did myself. Thank you, Nikolaos.
Thank you so much, Dominique. Thank you all. And thank you, ICSI, for the kind invitation.